risks, we start with this guideline, HIV. So risk of vertical transmission if a patient is breastfeeding, and it is particularly higher in African population. So the risk is, if the mother is breastfeeding, it is 25 to 40%. So if uh, the mother is breastfeeding, like you should, like mother is HIV positive, you should advise not to breastfeed, because if they're not breastfeeding, initially there was heart, now it has been replaced by combined antiretroviral therapy. Uh, then like they should continue CART, and they should not breastfeed. This reduces the risk of vertical transmission to less than 1%. It is around 0.57%. Okay. So breastfeeding, ideally in UK population, they do not advise breastfeeding to the HIV positive females. There are certain criteria. If the person is very much adamant to breastfeed, which we'll be discussing later on, that which all criteria should be met. Okay. Then for HIV, there should be universal screening. How can we screen? Either by antigen or antibodies. So there is a window period. For antigen, you get a positive test within 1 month, and for antibodies, you get a positive test within 3 months. And you should do STI screening also in all these females with it. So HIV positive females, for everybody, you have to do an STI screening also. Okay. Then about the psychosexual care for HIV positive patients. So HIV positive pregnancy, it is also considered as a high risk pregnancy, and MDT team should be involved. All these people form the part of MDT: obstetrician, specialist midwife, pediatrician, women's GP, health visitor, patients advocates, social workers, legal advocates, clinical psychologists, psychiatrists, counselors, health advisors, citizens advice bureau workers, interpreters, community midwives, pharmacists, adult and pediatric clinical nurse specialists, and health visitors. So all these people should be involved in the care of a female who is HIV positive. And you have to, if a HIV positive patient comes, you have to screen them for depression, and percent prevalence of depression in these patients is 30 to 53%. And when all should you screen for depression? This is again a question, recall question. You have to do it at booking, 4 to 6 weeks postpartum, and 3 to 4 months postpartum. So all these times you have to screen for depression. And how do you screen for depression? So there are Wooley's questions that you ask. So Wooley's question, it's a questionnaire to screen for depression. So it involves two questions where you ask, in the past month, have you felt loss of interest in doing things, or have you felt low, depressed, or lack of interest? So these two questions you ask. Okay. Am I clear so far?
Yes, ma'am.
Okay. Then breaking confidentiality. This is again one of the recall questions. So the question comes like that: a patient who is HIV positive, and she doesn't want to tell she doesn't want to tell her partner about the status. So what would you do? So what should you do according to, there is this thing in clinical practice, there is confidentiality. If it was not HIV, like if she had some breast cancer or some other thing, so then if she says she doesn't want to tell the partner, then you would respect her wishes. But HIV positive, if she's HIV positive, then you cannot, because there is a risk of transmission to the partner. Okay, so this is an exception to this confidentiality dictum. If she's HIV positive, you will tell her. So they give you options like you will tell the partner, you will try to convince her that she should tell the partner because of the risk of transmission, or if she like initially you will try to convince. If she still refuses, then again you will break the confidentiality and tell the partner. So the best answer would be, you will first try to convince the patient. Okay.
Okay.
And you should try that she only tells it, because you tell them that if, in case it would be better if you tell rather than us telling. Okay, so that makes more sense. Okay,
Okay.
so this is again one of the recall question. They give you a scenario and then they ask what will you do. So there are situations in which a woman given a new diagnosis of HIV may be reluctant to share this with the current sexual partner, or appeals to deny delay telling indefinitely. This can give rise to complex professional, ethical, moral, and potentially legal situations. There is a conflict between the duty of confidentiality to the index patient and the duty to prevent harm to the others. So breaking confidentiality in order to inform the sexual partner of the index patient's positive HIV status is sanctioned as a last resort by WHO. So it is a last resort. Like when you break, you will first try to convince. So they give you both the option that you will tell the partner or you will try to convince the patient. So the better answer would be you will try to convince the patient. Okay.
Okay, ma'am.
Then what are the investigations? So this also like again a recall question. So this also comes as like EMQ form. This type of questions like a when you should know when you are supposed to do all these tests. So what all tests do you do in a HIV positive patient? The first one is liver function test. Why you are doing liver function test? Because these antiretroviral drugs that you give, they are hepatotoxic. Okay, so that's why you have to do LFT at each, whenever you are doing a routine test, you have to do LFT also. Okay.
Okay, ma'am.
Second thing, if the female is, when do you do CD4 count? You do it twice. You do it at baseline. Like when if the patient is previously on cart, then you do it like when she comes for booking and then at delivery. If she was not on cart, then before starting cart and then at delivery. Okay. Then newly diagnosed females, what like if a patient, they again ask you question like a patient has been recently diagnosed with HIV positive. She's around 12 weeks period of gestation. So what will you do next? So what all tests will you do? You'll do LFT baseline. You'll also do CD4 count because you have to do the baseline. You also have to do a this viral load. You have to do resistance testing for all the antiretroviral drugs that you're giving. And after that, you will start the cart, and 2 to 4 weeks post cart, you also do the viral load to see the response to the antiretroviral drugs. So you do HIV RNA. So it is done 2 to 4 weeks after starting the treatment, then every trimester, then at 36 weeks, and then at delivery. So there is an importance of this because this helps in deciding in the fact that how will you treat the baby. Okay, whether the baby is low risk, high risk, very low risk. So this is important. Why? Okay, am I clear so far?
Yes, ma'am.
Okay,
Ma'am,
then
one
it
minute. What is that
yeah.
resistance testing, ma'am?
So like they test for resistance to a particular antiretroviral drug.
Okay.
So they give the
Just like
drug and see how the
culture sensitivity.
hmm?
Just like culture sensitivity, like.
It is not like culture sensitivity. So even like I'm also not very sure what kind of test it is given. It is done before you are starting the cart. So it is to see how the patient is responding. So probably they give the drug and then they see the response like that.
When we check the viral load, there may be difference.
Yeah. So this is before actually starting the full course of treatment, giving the full course.
Before treatment means like how do we get to know, ma'am?
I am really not sure about
Okay. It's
what
one of
I
the
feel is
points.
they give the medication like few doses and then they see how the response is.
Okay. Mm.
Yeah. So HIV resistance testing should be completed and results should be available prior to the initiation of treatment, except for the late presenting females where you cannot wait. If the patient has presented after 28 weeks, women should be encouraged to continue CART post delivery. But when they choose to stop CART, a further resistance test is recommended to ensure that the mutations are not missed with reversion during the off treatment period. So it has to be done for everybody before starting the treatment. So before starting CART, what all tests will you do?
LFT.
LFT, okay.
CD4,
Yes,
viral load,
okay.
and
Viral
resistance testing.
Viral load after the
viral
2 to
load
4
you don't
weeks
do
after
at
treatment, no, ma'am.
yes, yes. Viral load you don't do. You do it later. Then
CD4 count.
CD4, yes.
And resistance testing.
Resistance to STI screening also.
Okay.
Okay. And post this, like if the patient is already on CART, how do you monitor? What all tests do you do?
LFT we do, ma'am.
LFT at each whenever you're doing a routine scan.
Routine scan. Okay, routine
Yeah.
study.
Routine blood test
Screen.
af-
CD,
and other things.
viral
CD4
load.
baseline.
Viral load.
Viral load 2 to 4 weeks, and then every trimester, then at
Trimester
36 weeks, and then
and
delivery.
delivery.
Then
Same CD4 count, ma'am.
Baseline and at
no,
delivery.
CD4 count at delivery. Baseline
Delivery.
would have done
Baseline and
5.
delivery.
And
ST.
okay, fine. And other indications of doing HIV resistance testing is like in an event, a woman who has been initiated on CART during the therapy and her HIV RNA is not suppressed, then also you have to do the resistance testing. Okay. So in all these cases, you will review adherence, perform a resistance test, consider therapeutic drug monitoring, optimize to best regimen, and consider intensification of the doses. Okay.
Okay.
Yes.
Okay. Then what all drugs do you give for as a CART? So basically, if the patient is already on CART, you continue the same treatment, except one drug. This you should remember, dolutegravir. So dolutegravir, there is risk of neural tube defects. So for first 6 weeks, this is not recommended. So you will stop dolutegravir, and if the patient is there on dolutegravir, you have to give 5 milligram of folic acid. So this is something which you should remember. Otherwise, whatever she's on, you start. And uh, if the patient is not on dolutegravir, then you give a routine dose of folic acid, that is 400 microgram. So this was about this slide. Then other drugs like if you're starting freshly in the pregnancy, then the first line drugs are these NRTI should be the backbone. That is you have to give a 3-drug regimen. So first will be 2 NRTIs and third agent will be NNRTI. Okay. So it could be abacavir, lamivudine, tenofovir double dose, or emtricitabine. Okay. And other third agent could be efavirenz or atazanavir. And if the patient is on dolutegravir, you have to give 5 milligram folic acid. For 6 weeks, you do not have to give dolutegravir at all. If she's on it, you have to stop it. Okay.
Okay.
This is again one of the question about, they ask you question about dolutegravir. Okay. Then if the woman is not already on CART, when to start? So actually it should be started if she's not already on CART, you continue the same thing. If she's not on CART, it depends on the viral load and also the CD4 count, like when you have to start the CART. And CART has to be continued lifelong. And there is one term called as elite controllers. So elite controllers are those who have undetectable viral load and high CD4 count, but they are HIV positive, and they have this despite they are not taking CART. Okay, so it is like even if they are not on CART, if you do the CD4 count and viral load, it becomes viral load is undetectable, and CD4 count is high. Okay.
Okay, ma'am.
Understood. Then when to start CART in pregnancy? So if the viral load is more than 1 lakh and CD4 count is less than 200, so then you have to start CART really early, like in the first trimester. If it is viral load is between 30,000 to 1 lakh, you have to start at the end of second trimester. And if the viral load is less than 30,000, you have to start in the second trimester. But you, in all cases, you should not delay starting CART beyond 24 weeks. So you should try that you start before 24 weeks. Okay.
Okay.
Then this is how you decide. So women who conceive on CART, you continue the same. And if the patient is on dolutegravir, one you stop it like in the first 6 weeks, and second you give folic acid 5 milligram. Okay. And if the woman is not on CART, in everybody you start by 24 weeks, and this is the same thing which we have discussed. Based on the viral load and CD4 count, you decide when to start. Okay, and what to give? You give 2 NRTIs and 1 NNRTI. Understood?
Yes, ma'am.
So this was for the routine cases, but some people who present late. So then how do you manage them? Okay, if the patient presents late, suppose after 28 weeks, then you will not wait for the results of resistance testing. Okay. Then you will immediately start CART without waiting for the result of resistance testing. You will send resistance testing, but you will not wait for the reports to come. You will start CART. Or if the viral load is unknown or more than 1 lakh copies per ml, then you give a 3 or 4 drug regimen, which should include, this is another important point, that if the patient is presenting late, you have to give 4 drug regimen. So 4 drug regimen would include 2 NRTIs, which will be zidovudine and lamivudine. Okay. Then 1 NNRTI, that is nevirapine, 200 mg, which is a start dose. Then you have to give either raltegravir or dolutegravir, one of these. Raltegravir, the dose is 400 mg BD, and dolutegravir 50 mg or OD. And during labor, you also have to give them IV zidovudine. So apart from these 4 drugs, you have to give IV zidovudine. So this is again one of the questions they ask: when all do you give IV zidovudine to the mother? You give when if the viral load is more than 1 lakh, or she presents late in labor for the first time, she has not been on CART, then you give IV zidovudine. Okay, understood?
Yes, ma'am.
Then women with HIV positive who are not on treatment comes in labor. This is the same thing. You give start dose of nevirapine, IV zidovudine during labor and delivery, and oral CART, which should include zidovudine, lamivudine, and raltegravir or dolutegravir. This is again one of the questions, recall questions. Okay. Then for preterm babies, you have if the delivery is preterm, then you have to give double dose tenofovir. Okay. And in case the patient if the infant is unlive, why are you giving higher dose? Because sometimes the patient requires higher preterm babies, the absorption is not that good, so that's why you are giving higher dose. And sometimes the baby is on cannot take oral feeds at all, and is on either IV fluids or enteral nutrition. So in those cases, you give IV zidovudine to the baby. Okay, you either give oral double dose tenofovir, or you give IV. Like if the baby is not tolerating orally, then you give IV zidovudine. Understood?
Yes, ma'am.
This was about preterm. Then about the screening, antenatal screening. So the combined test for fetal aneuploidies and NIPT for those who are high risk. If the patient is high risk, you can do an combined test. But the thing is, there are some alterations because of the HIV can cause alteration in the results. So it can result in increased levels of beta HCG and alpha fetoprotein and lower levels of unconjugated estradiol. So results can be affected. And while a reduction in beta HCG in a patient is seen in patients treated with protease inhibitors or NNRTI based CART. Okay, so Down syndrome is also associated with increased HCG. Therefore, HIV per se may result in false positive rate in women and thus results in increased need for invasive test compared to normal population. PAP-A and nuchal translucency, they remain unaltered. Okay, and they are preferred methods of screening. Triple screen and quadruple screening is less reliable. Okay, understood.
Yes, ma'am.
So preferred screening will be the combined screen, or you do PAP-A plus NTNB. Beta HCG is still altered. And in case the patient comes out to be high risk and you're planning for invasive testing, that is amnio or CVS, then you should make sure that you can do invasive testing only if the viral load is less than 50. You defer it beyond that. However, sometimes what happens if the patient is of advanced gestation and you cannot defer the test. Okay, then what do? You commence the cart to include raltegravir, and the cart should include raltegravir and should be given in a single dose of nevirapine 2 to 4 hours prior to the procedure. Okay, understood.
Yes, ma'am.
So in case if the patient, you are thinking of doing an invasive test, if the combined skin screen comes out to be like comes out to be of high risk and you're planning for an invasive testing, then for invasive testing, you should, if you can wait, you should wait till the viral load becomes less than 50. If you cannot wait, then you have to start cart, and that cart should include this raltegravir and also nevirapine, which should be given within 2 to 4 hours prior to the procedure. Then about this thing about delivery, planning the delivery. So if a patient has breech and you're planning for ECV, or the patient is a previous LSES, or you're planning for delivery VBAC, you should plan for delivery only, vaginal delivery only if viral load is less than 50. Okay.
Yes, ma'am.
Yes, ma'am.
Okay, so vaginal delivery, you can go in HIV positive patients only if the viral load is less than 50. If it is more than 50, you have to do a planned pre-labor cesarean section. And it has to be done. This is again a very important recall question. It has to be done between 38 to 39 weeks. Planned pre-labor cesarean section between 38 to 39 weeks. Okay.
Okay, ma'am.
Less than 50, you can give a trial of normal labor. Suppose the patient has a spontaneous rupture of membrane and she is at term. Okay, then you have to deliver at like within 24 hours. And if the patient is less than 50, then only you can go for vaginal delivery. Then you will do IOL or AOL depending on the PV findings. If it is more than 50, then you have to do immediate. This immediate word is important. Immediate pre-labor cesarean section. Okay.
Okay.
Here it is not immediate. Here it is elective, planned. But if there is spontaneous rupture of membrane within 24 hours, you have to deliver. So you have to do an immediate pre-labor cesarean section. Okay.
Yes, ma'am.
Then this is at term. If the patient is between 34 to 37 weeks, then again you have to manage in the same way, but you have to give GBS prophylaxis also along with it. So it is the same thing which is written. Less than 50, you do immediate IOL or AOL plus GBS prophylaxis. More than 50, you do immediate cesarean section plus GBS. Understood?
Okay, ma'am.
Then if the patient is preterm, less than 34 weeks, then like you have to obviously give them steroids, you have to give them GBS prophylaxis, you have to optimize a viral load, and about the mode of delivery, you have to discuss with the MDT team. Okay, for the time and mode of delivery. And maternal oral nevirapine 200 mg start should be given more than 2 hours prior to the delivery, or double dose tenofovir double DF and standard dose raltegravir BD should be given. Understood?
Yes, ma'am.
Then indications of IV IWD. So if the patient comes in labor where like late in labor, patient was not on this thing cart and you check the viral load, it was more than 1,000, then uh, then you give, or if the even if the patient is on treatment and the viral load is more than 1,000 during delivery, then also you give IV side. Okay. So viral load more than 1,000 or untreated patients presenting late in liver, you give IV side only. So these are the two indications. Then this is again the same thing, planning the mode of delivery. So if the viral load is less than 50, you do vaginal delivery. 50 to 399, you consider viral load between 50 to 399, you consider pre-labor cesarean section. 38 to 39 weeks, more than 400, you recommend pre-labor cesarean section 38 to 39 weeks. Term spontaneous rupture of membrane, you have to deliver within 24 hours. If the viral load is less than 50, you do plus immediate IOL. If the viral load is 50 to 399, you have to consider pre-labor cesarean and you have to deliver, and it should be immediate. More than 400, again immediate cesarean section. Then if the patient is more than like 34 to 37 weeks, you have to do the same thing, but you have to give simultaneous GBS prophylaxis. If the patient is less than 34 weeks, then you have to give steroids, you have to control the viral load, and your delivery, the time and the mode of delivery should be decided by MD. Understood?
Yes, ma'am.
Ma'am, 1 minute. Uh,
Yeah.
Considering and recommending.
Hmm.
So when we consider, we are not supposed to do or we can do it.
See, consider means like ideally you should do, but they use these like in the this thing, no EMQs, they give these words only, consider and recommend. That's why I have put it. Otherwise more than 50, ideally you should do only, but
Yeah.
consider in the sense you should go for it. But if the patient is not willing, you can try vaginal delivery also. If the patient is in full labor,
Okay.
then
Okay.
like that, consider.
Okay.
So they
Thank you.
in the EMQs they will put these specific words, consider and recommend. So then you
That's
have to
what.
choose it like that.
Yes. Yes. Okay.
Okay. Then place of birth, like you can give a trial of this thing. Ideally, it should be in a obstetric unit in the hospital setting, and where there is direct access to pediatric care. And regarding water birth, like there is a scant safety evidence, but if you choose to give a water birth, you should make sure that obviously viral RNA load is less than 50. Then these are some of the questions, some of the scenarios. Anybody would like to take up? What will you do in these situations? Dr. Sharon, Dr. Gauri, anybody of you would?
Yeah, we are reading it.
Reading the question, ma'am.
Are these options, ma'am?
No, this
No,
is just a
no,
question.
no,
And what will
Entire
you do
thing
in
is
these
specific
question.
cases?
answer.
Entire thing is question.
That is between 30 to 1 lakh, ma'am. First,
Sorry, a 29-year G1P0 is now 13 weeks pregnant. She booked last week and her HIV test came out to be positive. She was cancelled about her results and would like to consider CART at 14 weeks. Okay, after the viral load done. So what are the tests you will order in these patients? You are planning
LFT,
to start CART.
LFT,
Yeah.
CD4.
Yeah.
CD4, and
Yeah.
other STD screening,
Yes.
Mm.
Resistance testing.
Resistance
resistance
testing.
test. Yes.
Okay. Next question. Like now the woman is 16 weeks, has been commenced on CART last week. Her liver function tests are normal. What will you do? What all will you check now? It has been 2 weeks since she has started CART.
Viral load, ma'am.
Yes, you'll do the viral load. Next question regarding to the previous scenario, and the woman has been diagnosed with HIV at 28 weeks of gestation. Screening for STI infections is negative and her RLFT is normal. A blood sample has been sent for CD4 count measurement. As she's presented late at 28 weeks.
So we can
What will you
start
do?
cart. We can start cart, ma'am.
Yes, you will start CART immediately. You will not wait for the results to come. Next, regarding the previous scenario, that woman who is known to be living with a HIV and on CART booked for antenatal care at 12 weeks, she is now 28 weeks into pregnancy. What will you do? She has been on CART and now 28 weeks.
Every trimester we'll be doing CD4, no, madam.
No,
CD4 you don't do. HIV
CD4 only
RNA,
baseline and at delivery.
HIV RNA you do every trimester.
Yes.
Okay, HIV
Yes.
load you will do and you'll
Viral
do
load.
LFT.
Viral load. Yes.
You'll
LFT
do
viral.
LFT and you'll do STI screening. That to anyways you do. So this were the answers. Okay.
Okay.
Then we have learned about how do we manage the HIV positive female. Then regarding the infants, how do we manage? So you have to give this post-exposure prophylaxis to the infant, and it should be started within 4 hours. And how will you decide what kind of prophylaxis you give? So it is based on certain criteria. So there are very low risk infants, low risk infants, and high risk infants. So very low risk, there are all the three criteria should be met. The first one is that the women has been on CART for more than 10 weeks, and there are second criteria is two documented viral loads at least 4 weeks apart is less than 50, and at 36 weeks the viral load that you check is less than 50. So if all these three criteria are met, then you give just one single drug, that is zidovudine, and you have to give 2 weeks of zidovudine. Okay. Then this again has been asked as a recall in as an EMQ question. So they give you scenarios. How will you treat the infant? So if the patient, you have to see if all these three criteria are met. You give 2 weeks zidovudine. It has to be started within 4 hours. Then if any of these criteria is not met, however, the RNA, like if the patient presents like at term, then at 36 weeks is less than 50, or like if it is pre-term, then whatever at delivery, whatever you have done HIV RNA is less than 50. At least this criteria, one value less than 50 is there. Okay. Then you have to, then again you have to give single drug zidovudine, but you have to give it for 4 weeks. Okay.
Okay.
Then high risk is when this HIV RNA is more than, okay, then that is high risk, and in which you have to give three drug therapy, like 3 weeks of three drug therapy. You have to give all these zidovudine, lamivudine, and nevirapine for 4 weeks. Okay.
So here in low risk, though it is less than 50, but only one test is documented.
Yeah. So all these
The
like
other one may be more than 50.
yes. No,
Anyone.
no, everything. No. You have
Hmm.
only one test, which is the latest test at the time of delivery. Whatever you are doing is less than 50. That is low risk.
Okay.
If she is preterm, then at the time of delivery, otherwise at 36 weeks. Okay. So all these criteria you do not need. If all these three criteria are met, then it is very low risk. If viral load is more than 50, then it is high risk. You can remember it like that. Okay.
Okay, ma'am.
Then when were you giving IV cytopenitin to the mother? What were the indications?
When she
Untreated,
presents late
when she
during
will labor, untreated,
and
Okay.
when she
more than
comes
1
in
lakh
labor.
viral load.
Viral load more than. Okay. Then and to the preterm infants, like if the patient is baby is preterm and is taking like tolerating orally, then what you'd give?
Sorry?
If the baby is born preterm and but tolerating orally, then what is a preferred drug that you give to the baby?
What is that? 10 of or something.
Double dose tenofovir you give. However, if the baby is not tolerating orally, then you give IV
Visa
Zydovirin.
delivery.
Okay.
Okay, because very premature neonate is at a risk of NEC if enteral feeding is commenced too soon or increased too rapidly. So to avoid that, you give IV. Then, if the patient is HIV2 positive, then you avoid NNRTIs because they are inherently resistant to these. Okay. So nevirapine will not be effective. NNRTIs are not effective in patients with HIV2 positive. So you give NRTIs on raltegravir, which is integrase inhibitor. Okay. Understood. This point is
Yes.
understood. Okay. Then PEP post-exposure prophylaxis beyond 4 weeks is not recommended. So even in high risk, you give three or four drugs only up to 4 weeks. Beyond 4 weeks, you do not give to anybody. Okay, and whether they are breastfed or non-breastfed, in in both, you do not like they give you a question like if the mother is breastfeeding, so you'll give PEP for what duration? Uh, they can give you option for 2 weeks, 4 weeks, or like till the duration of breastfeeding. So first you will find out based on the criteria what is the viral load, whether she has been giving it for more than 10 weeks, whether she has two values less than 50 4 weeks apart at 36 weeks, whether the value is less than 50 of the viral load. So if all these criteria she get low, she's very low risk, then you give it. You follow the criteria basically, whatever I've told you, very low risk, and high risk. So it doesn't matter. You will follow that irrespective of the breastfeeding status. Understood?
Yes, ma'am.
So
Yes, ma'am.
sometimes they try to confuse you like that. Okay. Then if the baby comes out to be HIV positive, then you have to give them this ART heart. You have to give them heart. Along with that, from for 1 month, you also have to give them cotrimoxazole prophylaxis. Okay,
Okay.
to protect against pneumocystis carni. Then immunization. So this is again one of the question because we feel that HIV is an immunocompromised situation. So we should not give BCG and rotavirus and all these live attenuated vaccine. But this is not according to the guideline. So they say that to follow the national schedule if the viral loads, especially if the baby is very low risk or low risk. High risk is a different thing. If the baby falls in very low risk criteria, you can give this rotavirus unless a infant is severely immunocompromised, and even BCG you can give at birth if the baby falls in this criteria of very low risk or low risk. Okay.
Yes, ma'am.
Then factors that increase the risk of HIV transmission via breast milk are who are not on cart include detectable viral load. Detectable viral load means viral load more than 50. Then advanced maternal HIV disease, longer duration of breastfeeding, breast and nipple infection or inflammation, infant mouth or gut inflammation, mixed feeding, in particularly solid food given to the infant less than 2 months of age. Okay, because that causes that.
Concentration means how long, ma'am?
6 months.
Okay.
Okay. Then in UK, ideally you should avoid the safest way to protect against HIV is to avoid breastfeeding. Then, if a patient wishes to breastfeed, then or like whom can you advise if they are adamant to breastfeed? Then they should be virally suppressed. They should be on cart with good adherence, and who choose to breastfeed should be supported to do so, but should be informed that still there is low risk of transmission, and they need to extra monitoring as compared to those who are not breastfeeding. And they have to infant should be reviewed, they have to be reviewed every month in the clinic, and up to the duration they are breastfeeding, and even 2 months beyond that. And maternal card rather than infant pre-exposure prophylaxis, it is advisable to minimize HIV transmission and through breastfeeding and safeguard the women's health. Okay, understood.
Yes.
Okay, then criteria to breastfeed. So the viral load should be fully suppressed. There should be good adherence, strong engagement with the perinatal MTT, prepare to attend monthly clinic for the duration of breastfeeding, and even 2 months beyond breastfeeding. And what should you advise? They should breastfeed, exclusively breastfeed, avoid mixed feeding for the duration of 6 months. And you should tell them specifically that in case there is breast infection or mastitis, or the baby has GI symptoms, diarrhea, okay, then they should stop breastfeeding for that interval, because then the risk of HIV transmission is more. Okay, understood.
Yes, ma'am.
So this is the thing, like for the breastfeeding, you have to tell them there should be no virus, no detectable viral load, healthy breast for the mothers, that is there is no mastitis, infection or inflammation, because if that is there, then there is increased risk of transmission. And happy tummies. Baby should not have diarrhea and vomiting, because if the baby tummy is irritated, it may be more likely that the HIV will cross into the bloodstream and infect the baby. If the tummy is irritated, like you may not absorb of your HIV medication properly. Only breastfeed if both of you have a happy tummy. So for both of them, there should be no diarrhea or vomiting. Okay.
Yes,
So
ma'am.
this advice you have to give. So this is a safer triangle for breastfeeding in HIV positive patient. No virus, happy tummies, happy breasts for moms. Okay. Then how do you follow up these infants who are HIV positive? So you have to do antigen testing and antibody testing. So the follow up differs in patients who are breastfeeding and not breastfeeding. So if the patient is not breastfeeding, for antigen testing, you do first test is done 2 days prior to the hospital discharge, like in day 2 and prior to the hospital discharge. In high risk patients, you do an additional test at 2 weeks. Okay. And second test is done at 6 weeks, and the third test in a low risk patient is done at 12 weeks. Okay, or 2 weeks after cessation of infant prophylaxis, because infant prophylaxis is 4 weeks. Understood?
Yes, ma'am.
So you have to do it at 2 days, 2 weeks if it is high risk, 6 weeks, and then 12 weeks. Okay, this is for non-breastfeeding. If it is breastfeeding, it is 2 days is same, then 2 weeks is same, then you have to do it monthly for the duration of breastfeeding, and then again monthly for 2 months beyond that. That is the same thing, 4 and 8 weeks after cessation of breastfeeding. Understood?
Yes, ma'am.
Then for antibody testing, so you have to take the first sample from the baby. If the mother status is like unknown, then you have to take, like on birth you take the first sample, and then for this seroconversion you take it at 6 weeks. Sorry, 6 months. That is around 22 to 24 weeks. Okay, so this is the same thing. And then
Okay.
you have to follow up these infants up to at least 18 months. And either you do it this at 22 to 24 weeks or 8 weeks post cessation of breastfeeding. So whichever is later. Understood?
Yes, ma'am.
So you're breastfeeding for 6 months. So 8 weeks beyond that you check for the seroconversion. Then how do you manage these patients if they come out to be HIV positive? So infants with positive result, one, you have to commence heart. Second, you have to give a cotrimoxazole prophylaxis after 1 month. Third, you have to like info if there is a positive test, the management will be according to Child's HIV Association and Pediatric CHIVA or Pediatric European Network of Treatment of AIDS or PENTA guidelines. A positive HIV in the infant should be fed back to the obstetric unit where the infant was born to allow investigation of any avoidable factors in transmission. In this question, so what category does the baby falls in?
Actually,
Very
why
low.
should she avoid breastfeeding here?
Very low risk, ma'am.
Yes,
Yeah,
she.
very low risk.
Hmm. So what should be the answer?
Option
E, ma'am.
Yes, so she should avoid breastfeeding and 2 weeks course of
Course
side.
of the dividend monotherapy.
Then postpartum management. So post actually whenever the cart is started, this point you should remember you have to continue it lifelong. Okay, and then the women should be called again for follow up after 4 to 6 weeks with MTT team. And a cervical cytology has to be done 3 months post delivery. You have to do a cervical smear testing 3 months post delivery. Then you should test the partner and other children for HIV. Then, if the patient has this hepatitis B along with HIV, then how do you manage these cases? You have to do all these tests. You have to do HBV DNA, HBe antigen, HAC, HAV virus, HCV, anti-HIV, anti-HCV, anti-HPV, LFT. All these tests you have to do. Then also you have to do LFT should be repeated 2 to 4 weeks after commencing CAR to detect evidence of hepatotoxicity or immune reconstitution and inflammatory syndrome, also known as IRIS, and then monitored regularly throughout the pregnancy and postpartum. Okay, so you have to do all these tests. Secondly, you have to monitor LFT, test for all hepatitis virus, and for hepatitis B, you have to do viral DNA and HBe antigen. And you should make sure that their card should include tenofovir DF. So this is important point. Tenofovir DF and emtricitabine or lamivudine should form the backbone of the antiretroviral regimen in treatment naive patients with wild type HIV, HBV co-infection and no contraindication to these drugs. If tenofovir DF is not currently part of CART, it should be added, or tenofovir alafenamide or emtricitabine can be added after first trimester. So this about this tenofovir DF, they have been, so I have highlighted it because it has been asked in the question. So you should basically make sure that in the card tenofovir DF is there. So this is one of the recall question from this thing. Okay.
okay, ma'am.
Then treatment of then also you have to give them hepatitis A vaccine if they have not been already immunized. So you give two doses, 0 and 6 months. Okay. And however, if the CD4 count is less than 300, you have to give 3 doses, 0, 1, and 6 months. Okay. So basically, if the patient is HBV and HIV positive, one, you have to do all the testing for all the hepatitis virus, and for HBV, you have to do HBV DNA, also HBe antigen. Okay, and then you have to check for HIV, HCV, HDV, HEV, everything, and you should make sure that tenofovir DF is a part of it. Then, if the vaccine for hepatitis A is not given, you have to give, and you have to decide on 2 or 3 doses based on the CD4 count. If the CD4 count is less than 300, you have to give 3 doses. Otherwise, 2 doses. Understood?
Yes, ma'am.
Then treatment for then postpartum management of co-infection of hepatitis B, and how do you manage these patients postpartum? So CART is a CART which is effective against both HPV and HIV should be commenced. So again, tenofovir DF should be a part of it. Hepatitis flares that occur after delivery should be managed conservatively. In absence of any obstetric complications, normal delivery can be recommended if the viral load is suppressed. So it depends on basically hepatitis B viral RNA. If it is less than 50, you can go for vaginal delivery, irrespective of hepatitis B viral load. Okay, this is again important. So here the viral load of HIV which matters, because hepatitis B is not transmitted that much through the vaginal route. Okay. Understood. This point is understood. You have to manage it according to the hepatitis B viral load. So I told you only if it is less than 50, you do vaginal delivery. Irrespective of hepatitis B viral load, even if it is high, if the HIV viral load is less than 50, you go for vaginal delivery.
Okay.
Okay. Then
Yes.
neonatal immunization also has to be given with or without hepatitis B immunoglobulin. And it should be given within 24 hours. This is again important. It has to be given hepatitis B vaccine and also plus minus immunoglobulin. I'll be telling you the criteria for immunoglobulin. It should be given within 24 hours. Criteria for giving immunoglobulin are if the HBV DNA is more than 1 million, that is 10 raised to power 6, or women is HBe antigen positive or anti-HBe negative. So if these three criteria are there, then you give immunoglobulin also. Okay, or anti-HBe status is not known. So these are the 4 criteria when you give hepatitis B immunoglobulin. Understood?
Yes, ma'am.
Along with the vaccine. And rate of transmission for HBsAg, if the if the mother is HBsAg and HBe antigen positive, then it is 70 to 90%. And if she's only HBsAg positive, HBe antigen negative, then it is 10 to 40%. Okay.
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 Then coming over to HIV and HCV co-infection. So confirmation, you have to confirm for the HCV viremia. You have to do this HCV RNA. PCR, basically you do it through PCR. Assessment of hepatic inflammation or fibrosis and liver function, and concomitant liver disease should be performed. Liver test should be performed. This is the same as for hepatitis B, that you have to, it should be repeated at 2 to 4 weeks after commencing CAR in order to rule out hepatotoxicity or iris, and then monitored regularly throughout the pregnancy and postpartum. Okay, so HCV routinely what we give ribavirin, but ribavirin you cannot give during pregnancy. So if the patient is HCV positive, you treat prior to they become pregnant, and then you ask them to get pregnant. Okay.
Okay, ma'am.
So ribavirin is not indicated in pregnancy. If the patient is HCV positive, patient is treated first, and then they should plan the pregnancy. And you have to give them both hepatitis B and hepatitis A vaccine if they have not been previously immunized. And vaginal delivery, you can go for vaginal delivery, and it will depend on the HIV RNA if it is less than 50. And continue CART postpartum and lifelong. Understood?
Yes.
So this was about HIV HCV co-infection. So this was all about this guideline. Any